Three.
Hi, welcome back after a very, very short break. And we are flipping back to H573. I thought we should get some last bit of testimony. As we heard, I don't know, was it yesterday or the day before, sometime this week, that, we have this system that has been developed for this multi-step process. And one of the, within the development of this, whether right or wrong, it is the way it is that this first initial certification after a warrant is being done in emergency departments. And as we learned, we have many emergency departments throughout our state that are staffed by physician assistants. And we're trying to clear a bottleneck to get people to the right care as quickly as possible. So I wanted the hospitals to come in and just talk about maybe like your thoughts on the bill, as well as the role that physician assistants play in our emergency departments.
Yeah, happy to do it. And Devin Green, Vermont, is a sorry, it's been a long week. Devin Green from VAS. Chair, you mentioned bottleneck, and I do want to say I appreciate the work that this committee has done in the past. We've actually made a lot of great strides in this area between some of the things like the urgent mental health care facilities and the mobile crisis units and some of your other initiatives. That's been a huge help. But I will say that waiting in the emergency department continues to be a big concern for our providers. And that is because an emergency department is no place to stay for a very long time. I think there is a perception of you bring someone to an emergency department and everything will be okay. But in fact, it's a pretty chaotic place. And research has shown that emergency department wait times longer than 2 hours for patients in need of hospitalization is associated with mortality, morbidity, and patient harms. And in fact, a long wait in the emergency department can actually be, when we talk about preserving someone's freedom, it can actually be counterproductive. And that's because, as one researcher pointed out, it's not hard to imagine that an individual in psychiatric crisis forced to wait alone for many hours in a small, unfurnished room, which is sometimes locked, or on a narrow gurney, might lose the control that he or she possessed upon arrival at the ED. That loss of control, in turn, will result in the use of force, and that individual who arrived at the ED with no need for inpatient admission has been transformed by the ED experience into someone who needs an inpatient bed. So our providers are very concerned with eliminating all barriers and really reducing those wait times. So VAS had extensive conversation with our chief medical officers, our emergency department directors, and ED nurse managers on this issue. And they all brought forward this desire to have PAs have the ability to do these emergency exams, the first certification. They were unanimous about it, and they all spoke to the professionalism and qualification of physician assistants to do these things. A physician assistant, if you go in there for chest pain, they are going to be the one who stabilize you and transfer you and assess you and everything else. So we are looking for parity with this bill so that people do not need to wait for a physician to come in and sign a piece of paper. Additionally, the role of the physician assistant has changed. So previously it was physicians supervise the physician assistant. In 2020, Act 123 was passed, and that changed the relationship from the supervisory role to just one of consulting, which physicians do with each other all the time. And so we really support this bill, and would ask that you pass it going forward. Happy to answer any questions.
I see Brian's hand, but to that point, can I clarify something?
Yes.
So do you know when this process was this process put in place before 2020?
Yes.
So at the time that this was created,
Right. It's
it
in,
made sense because physician assistants had to have supervision. And now they just have to have consultation, but this wasn't addressed. This came before. I guess what I'm saying, which came first?
the emergency examination first certification piece came before the Act 123 in 2020.
Okay,
I would say.
so it was created in a different world in which we currently live and practice.
Correct.
Okay, thank you for that. Brian, go ahead. Just wanted to.
I have 3 questions. I was trying to map them out to make it.
Wait,
So
let me get my pen out. Hold on.
First, do you know, if you don't, it's okay, but do you know or have an estimate of the average wait time for a first certification currently?
I don't. I heard that in testimony from yesterday. And while we do measure the time from when a person comes in to the time that they leave, we don't have that granular detail in our data.
So the next question is unlikely to be answerable, but I'm going to ask it, which is, do you have the average wait time for the next step? You know, like between
Like
the
the
first
first and the
certification and,
second?
yeah.
Well, it is supposed to be within 24 hours.
And if not, what happens? Can you remind us for the record? I know, but
So you may need to correct me on this, but I believe it sort of starts all over again.
right. I believe that's also the truth. All right.
Yeah.
The last one, I think you can answer. Then, because I mean, I thought you were to be able to answer them all. When you couldn't answer the first one, I'm like, you're probably. You don't select the info. But you did refer to statute saying that you have 24 hours and then you have to do it again. So actually, the maximum wait would be 24 hours because then you have to do the whole thing again.
Mhm.
Okay. But you mentioned parity.
Well, no, I think the maximum wait could be longer than that because you're starting the clock. You know, like you could be there for a number of days.
Oh, I meant till the next.
Oh, until
step.
the next.
Yeah.
Okay.
Right, because once you clear that once you're EE'd, you can be waiting for a bed and then they have to recertify.
Right.
So,
Okay.
And the only answer for that is more places for people to go.
Mhm.
But you mentioned parity, and I wanted to end with this one. That we heard some testimony saying that it was going to create an imparity to allow this. What I heard you and at least one other witness say is that this actually increases parity. So we're hearing like these conflicting messages. We heard an example from another witness about cardiac care
Mhm.
and how there are situations in emergency rooms where PAs will initiate an emergency cardiac procedure
Mhm.
or be the first step in the initiation of something that saves people's lives.
Right.
Do you see that as a parallel example to this, that if this could be a life-saving thing, and so if PAs are allowed to do that, why aren't we allowing them to do this life-saving thing?
100%.
I get that now. Okay. I'm starting to understand that better now, after hearing you in addition to that witness. Can you think of any other examples besides the cardiac one? You know, it's okay if not, but
Anything else that you're going into, because we
Anything.
have PAs. Some emergency departments are staffed only by PAs. So if you go in for anything, any sort of emergency, the PA is the one taking care of you. And here, what we have currently is the PA will interview the person, they'll rule out everything else, and then either they have to wait for the doctor to come in and sign off on it because they trust the PA, or the doctor has to go through everything again, which in addition to being in an emergency department, if you're in a mental health crisis and you're getting questioned with the same questions all over again, that doesn't help either.
there was another question related to this. Oh, that can you think of any examples where we don't let PAs have equal treatment? I don't know what the word is, scope of practice as doctors in terms of the front line of a process in the ER, like people come in, usually they go to like triage, and it's a nurse actually, like collecting info, checking them in, and then a doctor examines a person or a PA. Can you think of any other situation where, because the person told the triage nurse they were coming in for a condition, that we don't let the PA do it?
I cannot think of, like I can think of.
My brain trying to.
Yeah.
Yeah, I mean, so the other thing is like, things may be different in other areas, right? Like a PA specialty or something like that. But in the emergency department, everyone is treating that emergency. And the PAs are on the level as the APRNs and as the physicians.
I've been going through, I'm thinking labs.
Right.
They can order any lab any test, they can admit patients, they can get consultations from any, they could transfer the patient.
Right.
They can do an admission for a voluntary hospitalization.
Right.
I'm trying to rack my brain in anything where we would say, no, this profession doesn't have the expertise once they've received the training to actually be qualified to do this. And I'm just, from someone who knows an awful lot of physician assistants, I think I found it rather insulting of this really important profession. We rely on our physician assistants, our APRNs. It's not just doctors. And, I was thinking about the fair or the equity piece of it. And why should somebody in rural Vermont be subjected to different standards as somebody in Burlington? So just because of how their hospital is. Brian and then Leslie. Sorry,
But
I went off on.
But I heard you bring up geographic equity, which is important.
Yeah.
I want to go back to the, I'm really trying to give everyone's perspective an equal say and trying to understand. So that's just to be clear, like, that's why I'm asking these really specific questions. But can you think of any other medical situation where a person's rights get taken away besides this process? Like, is there any other situation where a person could come into a hospital and present with symptoms and have healthcare providers initiate a process to take away their freedom besides this emergency evaluation process that begins with the first certification that we're looking at?
I think intoxication is one thing.
Can you say a little bit about what happened? I don't want to.
Yeah, loss of consciousness. There is a process for intoxication where someone is, and the word is, they don't have their full faculties due to intoxication and.
Like incompetent or incapacitated.
Yes, thank you. Thank you.
But then the hospital can say, if the person tries to leave. So here's the thing, if you try to leave and they're like detaining you, you can leave against medical advice in many situations, but there's ones where they don't let you leave, like this. With
You're
intoxication,
incompetent.
if you're trying to leave, they can hold you back. They can call the police to come, like, keep you.
I
believe
have
the
to
police
look
bring
at
you to
that.
jail if you try to leave in those situations, but I could be wrong. They can try to like
I
drive
don't
off.
know for sure. I mean, this is definitely this is very much this brings in a legal perspective that you don't necessarily see in other areas of the healthcare world. But I will say that there are times when people they don't necessarily have this process, but they are probably unable to leave due to their incapacity. And it would be unsafe for them.
So it sounds like there's some nuance between these different situations, and that this is one of many examples of situations where someone's medical condition could lead to them not having the same rights that they would have otherwise, because their competency, I heard consciousness mentioned. I think that's fair to say, like state of mind or state of consciousness. You don't have the same rights because you're unconscious. So people are making decisions for
You're not
you
able to make
try with the
decisions.
best, with the best intention, but they might do something you don't want. That's why people have orders to not resuscitate,
Right,
so that they can follow your will when you're not there.
right.
But I think what we're getting at here is this is a unique medical situation. And so the argument we were hearing from others was that because people's rights were being violated, or not violated, because it's not a violation, it's more like restricted
Mhm.
because of your health condition. And it's really related to safety. It's not about like harm, it's about safety. So restricting someone's rights due to safety concerns, due to a medical condition, this is very unique. But it sounds like there may be other nuanced examples around, like you mentioned, intoxication, or there could be some medical conditions where a person is delirious or something. Okay, but they don't have to go before a judge.
Right, there's not
Yeah.
this process for that, but there is like, according, oh gosh, so I would want to go back and look at that, but I think the major concern in this piece is this process creates harmful delay unnecessarily, because you have someone who is qualified to do this work available, and we have some law that's saying you need to bring a different person in to do this work.
And then those other situations, the PA can do it.
Right.
And that's why this is
For
not
voluntary.
It's that's the imperative. I see your point. Yeah. Thank you for elaborating and giving us some detail.
And I just want to ground us. Because I think some of the testimony that we heard yesterday was not relevant to this particular bill. I want to ground us in the chart that Katie began with. That, there is a first step in the process, which is a qualified mental health professional or a judge has to secure a warrant just to be able to bring the person to the emergency department. And, we're talking about, is there any other level of taking someone's rights away? I want to remind us, this step is not taking the person's rights away. There is a mechanism for that, which is the psychiatric, which we keep hearing concerns about that piece of it, but this bill doesn't address that piece of it.
That's right.
This is just getting the person to the next step where a qualified psychiatrist can make this determination. Right? This is not a PA in some hospital deciding whether or not somebody is going to be involuntarily admitted.
Right. And this is a PA determining, does this person need inpatient care? And they do that all the time for heart attacks, for voluntary folks, for
voluntary
anything else.
psychiatric.
Yes.
Yes.
So it's even creating an imparity between voluntary and involuntary psychiatric if we don't do it.
That's right.
Okay.
Leslie, yes, I'm sorry. I know
course.
you had a question.
So I'm wondering, in all your conversations with the medical directors and all those kind of people, did they comment on the DMH training that was required for people doing emergency EEs, emergency evaluations? Or because DMH initially, testified that was required,
Mhm.
and and sort of stood behind this as a
Yeah.
appropriate
Yeah, I don't see why the PAs couldn't do the DMH training. I think it is appropriate to have a special training for this. There's a legal component. And so physicians do it, APRNs do it. I think it would make sense to have PAs go through it as well.
So I understand that there are instances, if the PAs are not allowed to do this, that they may call someone down from the floor, a nurse practitioner or a doc, but maybe neither of them have trained in this particular set of DMH protocols and doing an EE without that training.
No, you have to have that training to do the EE.
Okay, because I was
Yeah.
sort of,
I think,
I'm not 100% sure of that, but because,
yeah.
okay, because there was a nurse
Testified
practitioner.
on that the first
Yeah,
time.
yeah, but I've heard from nurse practitioners that they've had to go down and do it
When they have.
when they work on the floor. So maybe I misunderstood,
But
totally
maybe
possible.
they've received the training.
Right.
They might have.
They probably
But that
have
wasn't the
to.
comment. The comment, well, maybe the comment was more they were being taken away from floor work.
Correct.
In order to do this thing.
Correct.
Okay.
And we've had, doctors or APRNs who have been called in to come in from home, and that adds a bunch
Yeah.
of time as well.
A bunch of angst. Okay,
Yeah.
thank you.
Yeah, I think DMH testified the first time that anyone who's qualified for doing this has to receive the training.
Yeah.
Okay.
Thanks.
Oh, go ahead, Wendy.
One that I'd like to put out there is that it's not, and I definitely understand the gravity of this situation, that somebody's making a life altering decision for somebody else. But we're talking about the price of care too, and if you have to have somebody else come in from outside to do something, that seems like a first step. I mean, this is not the final step in anything. It just seems like now you're double billing. It's just, that's all I have to say.
Yeah,
No,
that
thanks for
component.
pointing that out. Go ahead, Daisy.
There was one point that came up, I don't remember where. And I have a question about QMHPs versus physicians.
Mm-hmm.
I don't know if you can answer this, but a line in the bill, I believe it's at the bottom of page 1, reads, upon written application by an interested party, blah, 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 blah. That's where everything starts. So we're proposing to scratch interested party and replace it with a qualified mental health professional because that's who's
How it
doing
works.
these.
Yep.
Someone noted that actually physicians can also do these, but they are not included under qualified mental health professionals. You want to weigh in on that?
You would need to go and look back at that because I thought they were included in there, but I would need to look at the definition again, just to make sure.
Oh, wish Katie was here.
I
I think I remember, I feel like I'm going back in my memory that there is a definition of that was in something else that we did in this very same question. Was that?
There is-
Yeah.
And yes, they would be by virtue of their training. Okay, thank you.
Thank you.
Thanks, Deb.
I did wanna, we have reached out, a couple times. I just wanted to make note, to the Board of Medical Practice. The Board of Medical Practice is who licenses both physicians and physician assistants, just on, their thoughts on the bill and as well additionally, that maybe they would be able to, explain the qualifications and the expertise and training of physician assistants and the role they play. But I just wanted to make a note that they were unable to come in. So I did try for that testimony. But I think Devin very capably handled that. All right. I would like to vote on this bill today before we go. Should we take a 5-minute break?
Without Devin and Lori? I'm okay with it. I'm just saying, like, are they not
Yeah,
here?
no,
Okay.
I know that,
That was not on Zoom. Okay.
we're running out of time, people.
We do have to be moving. I just was checking.
Let's take a short break just for